Good morning. I'm Lord Brodie, Chair of the Scottish Hospitals Inquiry. The inquiry was established to investigate the construction of two hospitals, the Queen Elizabeth University Hospital campus in Glasgow and the Royal Hospital for Children and Young People and Department of Clinical Neurosciences in Edinburgh. In the summer of 2024, the closing hearing relating to the Edinburgh Hospital took place, concluding 31 days of oral evidence. I heard from 43 witnesses in person, including those affected by the matters under investigation, experts and key decision makers. Core participants and witnesses shared hundreds of thousands of pages of documentation with the inquiry, which the inquiry team has analysed. Today I publish my interim findings that relate to our investigations into the construction and opening of the Edinburgh Hospital. It's an interim report, and it may be that, having heard further evidence in relation to the Queen Elizabeth University Hospital, I will require to revisit matters relating to or raised in connection with Edinburgh. In such an event, they will be addressed in a further report. As is set out in the report published today, on the 4th of July 2019, the Cabinet Secretary for Health announced that the opening of the new Royal Hospital for Children and Young People and Department for Clinical Neurosciences in Edinburgh would be postponed. This was due to the fact that it had been discovered that features of the ventilation system did not comply with the authoritative guidance applicable to certain critical areas of a hospital. The hospital had been due to open fully on the 9th of July 2019, and the announcement came the day before equipment, staff and patients were to begin moving onto the site. The financial cost of the delay was reported to be £16.8 million. But in addition to this, there can be added the commencement of periodical payments to the contractor, notwithstanding that the new hospital could not be occupied and the need to retain in operation the existing facilities, which the new hospital was intended to replace. Following remedial works, the hospital was only fully opened on the 23rd of March 2021. The decision not to open the hospital as planned had a significant impact on patients and their families, who were shocked, scared and deeply disappointed that long-promised new facilities were not to be available for the treatment, in some cases, of children suffering from very serious conditions. Patients and their families were left in the dark as to the reasons why the hospital did not open as planned. Communication with the patients and families was unsatisfactory in this regard. I've seen this to have been important. It is to be remembered that there is a group of young patients who are very seriously ill and who spend a significant portion of their time, sometimes much of their lives, in hospital. They are supported by their family members or guardians. The hospital becomes, for them, their second home. The impact of unclear or poor communication on the well-being of patients and their families during what may already be a very difficult, emotional and uncertain period in their lives is significant. Accordingly, the first of my recommendations is that an effective communication strategy must consider the lived experience of patients and their families and their need for information, transparency and support. The issue that led to the decision to delay the opening of the two facilities in Edinburgh related principally to the design of the ventilation system of the paediatric critical care department, and, in particular, the pressure differentials and air change rates that the system was capable of achieving. It is generally accepted that specialized ventilation systems in hospitals have a role to play in protecting vulnerable patients from airborne sources of infection. This is reflected in guidance entitled Ventilation for Healthcare Premises, which is set out in Scottish Health Technical Memorandum 0301. This guidance document contains recommended air change rates and pressure differentials for different areas within a hospital. The subcontractor that designed the mechanical and electrical building services understood itself to be designing and delivering a ventilation system that was compliant with this guidance and that met NHS Lothian's requirements. The weight of the evidence available to the inquiry indicated that it did not. On the basis of the evidence that I've heard, I've concluded that in a project for the construction or refurbishment of a healthcare facility, it is the health board, as the prospective provider of that healthcare, in consultation with relevant stakeholders and clinical and technical advisors, that is best placed to identify what it requires from the ventilation system. This includes the precise output parameters that the ventilation system must meet. Accordingly, determining the output parameters of a ventilation system should not be left to the judgment of the project company and its subcontractors during the design phase. The design process should address how previously determined parameters are to be achieved, not what should be achieved. In relation to this project, it is my conclusion that NHS Lothian did not present its requirements for the output specifications of the ventilation system with sufficient clarity and precision. Rather, it relied on more general references to Scottish Health Technical Memorandum 0301 in its contractual documentation, which were then left for the contractor to interpret. However, NHS Lothian also provided to the contractor a document entitled the Environmental Matrix, which provided output specifications for the ventilation system. This had originally been developed at a stage in the project when it was intended that it should be capital funded, whereas it was later changed to a revenue funded model. As it happened, the environmental matrix contained an undetected error in relation to the parameters for certain critical care rooms, thereby leading to a lack of clarity as to whether NHS Lothian required full compliance with published guidance or whether the environmental matrix was intended as a derogation from that guidance. This use of the environmental matrix after the change in funding arrangements occurred without a sufficient assessment of why it was being done and how doing so might impact on parties' understanding of its significance and on their contractual relationship. What this project demonstrates is that risks can arise if design or briefing material generated in the context of one funding model is used without proper assessment of the risks of doing so after the funding model has been materially changed. Therefore, my second recommendation is that a risk assessment is required if there is a change in the arrangements for funding a project. But it is also critical that a health board formulates and then articulates its requirements in terms which are full, clear, and unambiguous, and that this brief is finalized before a contract is signed. Therefore, my third recommendation is that a health board's brief for the construction or refurbishment of a healthcare facility must be clear and must identify the output specifications to be met in accordance with guidance. Questions were raised during the evidence heard by the inquiry as to the potential for difficulty in the interpretation of the guidance contained in the then current version of SHTM 0301. Revised and clearer guidance has now been issued, with further versions currently under preparation. The revised guidance also introduces a mandatory role for a multidisciplinary ventilation safety group to oversee the design and management of hospital ventilation systems. I see this development as likely significantly to reduce the risk of misunderstandings on future projects. The former Cabinet Secretary identified gaps in how the Scottish Government obtains assurance and provides support to health boards on technical matters. Significant and substantial steps have been taken to address the gaps with respect to assurance and to improve support to health boards on technical matters through the establishment of NHS Scotland Assure. A range of procedures now exists to help to ensure that health board projects meet appropriate standards. While there have been improvements, there is room for more to be done. For example, to avoid the duplication of procedures, to more clearly define the roles of those involved in healthcare build projects, and to provide relevant training. I have mentioned 3 of my recommendations. I have made in total 11 recommendations in the interim report, and these can be found in full on the Scottish Hospitals Inquiry website. The work of the inquiry continues. 3 separate hearings have been completed in relation to the Glasgow hospitals, but further evidence requires to be heard, and preparation for that is ongoing. However, I would wish, in presenting this interim report, to take the opportunity of thanking, first, all of those who've participated in the hearings to date, especially patients and their families. Their assistance has been invaluable. And secondly, I would like to thank the Scottish Hospitals Inquiry team for their hard work and dedication, which has been and continues to be vital to the successful fulfilment of the terms of reference that the inquiry has been set. Thank you.